Hello and good evening. I'm Dennis Shelby, and we want to welcome you to the 2016-17 series of webinars on war-related stressors and trauma. These lectures are brought to you by the Service Members and Veterans Initiative of the American Psychoanalytic Association. Last year, we presented a series of webinars that provided a wide arc through the considerable psychoanalytic contributions to understanding war-related distress and trauma. And this year we're focusing on single author contributions, either researchers, authors, leaders in the field. We've been fortunate to get some really important people here. And this is our last webinar for the fall. We'll have 3 more in the spring, so watch your email and those will come up. Now tonight, our first speaker, and we are quite lucky to have him, is Dr. Robert J. Ursano. He's professor of psychiatry and neurosciences and chairman of the Department of Psychiatry at the Uniformed Services University of the Health Sciences at Bethesda, Maryland. It's a pretty amazing place if you've ever been fortunate to be there. And he's the founding director of the Center for the Study of Traumatic Stress. In addition, he's the editor of Psychiatry, the Journal of Interpersonal and Biological Processes, founded by Henry Stack Sullivan. And Dr. Ursano completed 20 years of service in the United States Air Force Medical Corps and retired as a colonel in 1991. He was educated at the University of Notre Dame, not 45 minutes from where I'm sitting, and the Yale University School of Medicine, and did his psychiatric training at Wilford Hall United States Air Force Medical Center and Yale University. Now, a couple of his awards and honors. He's received the Department of Defense Humanitarian Services Award and the highest award of the International Traumatic Stress Society, the Lifetime Achievement Award for outstanding and fundamental contributions to understanding traumatic stress, and he's a recipient of the William C. Porter Award from the Association of Military Surgeons of the United States and the William Menninger Award of the American College of Physicians and the James Leonard Award of the Uniformed Services University. He is the co-principal investigator of the largest NIMH grant ever awarded for the study of suicide in the U.S. Army. In collaboration with his co- and site principal investigators at Harvard, University of Michigan, and the University of California, San Diego, the Army's STARS grant is designed to be the Framingham study of suicidal behavior. Army STARS addresses an important national as well as DoD, and recently was renewed for its second 5 years. He and his colleagues recently reported their identification of a potential genetic biomarker for PTSD and the findings of decreased telomeres length in special operations soldiers with PTSD. And if that isn't enough, he has over 300 publications. Do you sleep? He's the co-author of or editor of 20 books and volumes. In the past 5 years, the Center for the Study of Traumatic Stress, which I think you helped found, didn't you? Has had over,
right.
Pardon me?
Correct.
All right. Has had $150 million in research grants. So that's a thumbnail sketch of Dr. Ursano, and I'm going to turn it over to him.
Thank you. Very gracious. Perhaps the most important thing to keep track of is I like to understand why it is that people exposed to trauma have such great suffering, and that applies in particular to war, but war is one particular type of what we think of as disasters, and that understanding the effects of war informs how people respond to disasters, and understanding the effects of disasters helps us understand the effects of war. I have no disclosures, which I always like to say, and whenever we're talking about war, I like to open by noting that, of course, war itself is an ethical problem, since we're talking about disclosures and ethical dilemmas. Disasters, closely related to the questions of trauma, mean that we often have to decide who we treat and who we might not. We have to decide who must return to a war to protect us, despite the fact they may be exposed to bad things. And it's certainly true that in many aspects of medicine involve pain in order to give care, and that can be true in treating PTSD as well. Importantly, with families, it's also important to remember that war leads to injured families and not just injured soldiers. And that lastly in this list, but certainly not lastly, that those exposed to trauma are often challenged to manage the issues of the moral injury they feel because of their participation in what can be anything from injuring civilians to, in disasters, firefighters needing to leave those who are injured and move on to fight the fire. All of these issues are ethical challenges that lie in the face of confronting war and are a part of our trying to understand the experience of trauma. The experience of war is endemic across the world. I think there are presently about 26 armed conflicts going on throughout the war. The one most recently in the United States, of course, is the Iraq-Afghanistan conflict, which has been our longest ongoing war, and it still continues. Much of the challenge of that war presently being borne now by special operations forces. As I mentioned earlier, that war falls into the category of a particular type of disaster. And disasters we often categorize in the human-made and natural. And war is one of the human-made disasters. And it carries some characteristics similar to other human-made disasters. When we think of the broad outcomes of exposure to traumatic events, notice I'm always talking about exposure to traumatic events. I'm not talking about the experience of trauma, which is a very confusing phrase to use. It confuses the event with the outcome. And in order to better understand how traumatic events affect people, we need to clearly distinguish the event from the outcome. And what are the characteristics of the event and how that may relate to various types of outcomes, such as in this slide, remembering and important for a psychoanalytic audience, the broad range of exposure outcomes related to exposure to traumatic events. In the bottom left corner, you'll see mental health, and in fact, most people do fine and are resilient. Doesn't mean they aren't changed. And there's also illness, the most classic, of course, being PTSD, but there are other disorders associated with traumatic event exposure, including depression and panic disorder. In the top, you see the most common responses, which are distress responses, which are changes in sleep, decreases in feeling safe, deciding to stay home and isolate, all of which can become symptoms and targets for psychotherapeutic intervention. And then in the bottom right, health risk behaviors, often forgotten. But in a psychoanalytic, psychodynamic world, we're often focused on feelings and behaviors, not necessarily disorder. It is altered behavior that can also occur following a traumatic event, such as increased smoking or increased use of alcohol. Notice I say increased, not the development of alcohol disorder, but that one may drink more. And why is that important? Because if you drink more, you're more likely to have more motor vehicle accidents. You're also more likely to be involved in spousal violence or child abuse or crime. Similarly, there are behaviors of over-dedication that we see in first responders. And say after 9/11, we see decisions about changing one's travel and staying at home, and the experience of not wanting to leave home. All of these behaviors are important outcomes of exposure to traumatic events, and all of them require understanding in order to be able to treat. A well-known at this point perspective is to remember that when we think about the responses to traumatic events, PTSD in particular, but also others, there is also the characteristics of the trajectory of the response. And that what determines the trajectory is only now beginning to be studied. It's not the same as deciding whether or not one has a disorder or not, but is that disorder persistent? Is it one that we can anticipate recovery from? Is it one that has a low level of symptoms that never reaches diagnosis, which would be line number 1 there? Or is it a late onset, such as line number 4? To the extent we can anticipate the trajectory, the course of a response, we're better able to think about treatments. And we also have to think about treatments that modify the course, not just the presence or absence of the disorder. And the predictors of what predicts the trajectory may be quite different than what predicts the disorder itself. And one of the unique opportunities in psychotherapy and psychoanalysis is, in fact, to observe the course over time. I wish there were more studies of those who are observing those exposed to trauma who would describe the course over time of 1 or 2 symptoms, not the course of a psychotherapy, which is very complex, but in fact to track 1 or 2 symptoms across time as it changes, and what you think may have been the elements that related to the change in those 1 or 2 symptoms. In the next slide, we can see again some of the trajectories of PTSD after injury. This was done by Richard Bryant and is an empirically based study, and Richard is one of the folks who's been very focused on trajectory, as well as George Bonanno. And again, the question of what are these trajectories? In general, there are 4 that are found. In this particular study, there were 5, but you get the sense that the most often trajectory is resilience, which is most people do not develop disorders, and then a few people develop, in fact, chronic disorders that persist over time. If one looks at the difference between intentional and non-intentional traumatic events, one can also begin to think about how the type of event may influence the trajectory over time. In this particular study done by Pacho Santiago at our university, which was a literature review and a meta-analysis, you could see that the non-intentional injury was associated with a much more positive trajectory, while those who experienced intentional traumatic events were more likely to have a sustained and chronic disorder over a 12-month period of time. This is really illustrative of our need to better understand the elements of a traumatic event. How do traumatic events differ, and how do those differences predict the trajectory that may be present? And of course, those differences exist in both the event itself as well as in the person who's experiencing those events, and that person's history, their present connectedness, and their anticipations about the future. An important part of psychiatric care is still illness in the community, and understanding the relationship between community and the development of illness can be another important element of predicting how will a community which has experienced a disaster, a war, a terrorist attack, be able to recover. There are several unique studies on that that bring up unexpected findings, such as Peter Steinglass and Ellen Garrity have a remarkable observational study many years ago following a tornado and looking in 2 different communities, one of which was high-resourced and higher socioeconomic class, and the other was poorly resourced and poorly socioeconomic class. And they looked at which community recovered more quickly. And counterintuitively, it was the community with lower resources that in fact recovered sooner and better. And the way they understood that was the way in which the community responded to the disaster. They were much more supportive of each other and worked together, while in the high resource community, the individuals tended to try to manage on their own. So this slide that I have up present is one in a similar type of study which we did, an empirical study, looking at Florida in 2005. There were a series of hurricanes, 5 in fact, which struck Florida. And in a study done with Dory Reisman from the CDC and the Public Health Department of Florida, we studied the impact of the hurricanes on the public health employees who had to respond to the disaster. With collecting data on them, we also collected data on where they lived and what zip code they lived in. And we were able to score each of their zip codes on a concept called collective efficacy. Collective efficacy is a concept of James Sampson, used to be at the University of Chicago, now at Harvard. Originally, he used it to predict adolescent violence in the community. And collective efficacy measured the strength of a community based on things such as how likely do you think you would be able to obtain a cup of sugar if you had to borrow one from your neighbor next door. You get the idea that it's a community support measure. So in this particular slide, we looked at rates of PTSD based on the level of collective efficacy being scored from 10 to 50, 1 to 5 on the bottom. And we looked at individuals that had low personal injury or high personal injury, meaning they had had injured members of their family, or their house had been very destroyed, or their car had been destroyed. And interestingly, these were all adjusted for the degree of destruction that was present in their own community using FEMA scores. And what you can see is the greater the community strength, the lower the probability of the percent PTSD. So the percent of the population with PTSD goes down, the stronger the community. And that's true for both low injury and high injury individuals. We did a similar study looking at depression with somewhat similar findings. So we've talked some about exposure mattering, the type of traumatic event we need to know more about. Trajectories matter, and trying to think of what is the trajectory of this patient or this community over time. And we've talked some about an unusual aspect of support, not often studied, but that's the collective efficacy. Similar in the military, one would think of unit support. But let's glance a little bit at DSM-5 and see how it informs us. I had the opportunity to serve on the DSM-5 committee that was chaired by Matt Friedman. And one of the most important outcomes of that part related to trauma was the new name of the chapter. So number one, PTSD is not a part of the anxiety disorders chapter. It's now in a chapter on its own. And you'll notice that the chapter is trauma and stressor-related disorders. The point of naming the chapter that way was anticipating better descriptions of additional disorders to include in this chapter, where now we don't have a trauma-related depressive disorder because no one has been able to show it's different from other depressive disorders, but maybe it is. Should the proposed diagnosis of prolonged complex bereavement disorder, not yet recognized as a disorder, but certainly talked about under the rubric of traumatic grief, it would also become a part of this chapter. Is panic disorder, which we know can increase after traumatic events, is there something unique about it when it's related to a traumatic event? The wonderful thing, again, about psychotherapy and psychoanalysis is the micro observation that goes on. So that in performing therapy or analysis, one is always interested in what's the event that precipitated this behavior or feeling. A unique opportunity to contribute to understanding new behaviors, feelings, and disorders that will eventually belong in this chapter. Within the DSM-5 PTSD diagnosis itself, there were some substantial changes, which you may know well. But one I wanted to draw your attention to is, again, are there differences we need to be learning about, one of which we felt we know enough about to, in fact, indicate that it should be designated a subtype, which is PTSD with persistent dissociative symptoms. And thanks to Ruth Lanius, there is sufficient data to say that PTSD that has persistent dissociative symptoms, and here you'll see it listed as persistent or recurrent depersonalization or derealization, that in fact they tend to have a different course, they have a different neuroimaging, and they may actually respond differently to treatment, but we don't know that yet. Under acute stress disorder, there was also an important change that took place reflecting our new knowledge, which is that dissociation is no longer required for acute stress disorder. Now, why is that? Well, the simple answer is that we found that everybody that gets PTSD didn't have this ASD beforehand, and everybody who has ASD beforehand didn't get PTSD afterwards, and that we had thought that dissociation was going to be the link that made that true, but it's not. So that one can have acute stress disorder without dissociation, or you can have acute stress disorder with dissociation. It's no longer a required element of the diagnosis, and there's no presumption that ASD is predictive of PTSD in an exclusive way. And I mentioned earlier the proposed, but not in fact yet a diagnosis, persistent complex bereavement disorder, which is in the appendix and meant to stimulate further study of chronic ongoing bereavement that persists greater than 12 months, similar to, very close to the work of Holly Ferguson and Catherine Shear. And Catherine Shear has a wonderful intervention based around cognitive behavioral therapy, but well informed by psychodynamic and psychoanalytic thinking directed towards traumatic grief. So what do we know about predicting PTSD, and how does this inform us about thinking about our patients? Well, in the present most recent war in the United States, and published in the New England Journal quite a while back, we know that the greater the number of firefights a soldier was in, the more likely they would develop PTSD. But in fact, that's not news. This is a slide that you'll see now, a graph of the wounded and killed in action and the psychiatric casualties. And this is from World War II. You'll note that the slide, the curves move in unison. The more stressful the battle, the higher the rate of psychiatric casualties. In fact, that's true of war. It's true of all trauma and all disaster experiences. And one of the most often reported findings, the greater the traumatic exposure, the higher the probability of developing PTSD in particular, and the higher the rate of psychiatric disorders. A very important study done, I guess I don't have that slide in here, but it was done after Katrina. This Katrina hurricane, which occurred primarily hitting in Louisiana. And Ron Kessler, and I was a part of the study, were able to do an epidemiologic study of New Orleans and greater New Orleans after the Katrina hurricane. Importantly, there had been a similar epidemiologic study using the same measures approximately 2 years before, so that we were able to compare what happened to the rates of psychiatric illness comparing pre and post in that large geographic area. And it's one of the few studies of a large disaster zone that actually has such pre and post data. And in fact, the psychiatric disorders doubled after Katrina. Again, exposures matters. There's substantial data that in fact, people who don't have disorder can get disorder after traumatic events, and that the more stressful it is, the more likely there will be disorders. Another type of outcome, this in war, but it just has not been examined in disasters, is a part of our group looked at rates of child neglect during the times of the war here in the United States. And you'll note that the war started in 2001, and you will see the increasing rates of child neglect as the time went on. This is for 1 and 2 year olds, but actually the data is there across all the way up to teenage, age 12. One sees this similar uptick in child neglect occurring, this is in the Army, occurring during the time of the war. So why is that? Well, what is the strongest predictor of child neglect in previous studies? And the answer is being a single parent. It's hard to raise children. It takes a great time and energy, and it's even harder to raise them if you're the only one doing it. What do we do when, in fact, an army goes to war? Well, we deploy soldiers, and therefore we create single-parent families. So, in fact, we do this study that you could never do, which is go into a community, turn families into single-parent families, and then measure the rate of child neglect. And not surprisingly, they go up. This was an important finding and one that the Army was very responsive to moving resources to assist the parents of children while their soldier serviceman was deployed. And again, highlights the complexity of how trauma, particularly war, impacts on individuals and a community. And it would be something we would see in our patients when their spouse or partner was deployed, the increased burden that they felt and the higher probability of their being someone who neglects their child because of so much to do and so little resources and time and energy to do it. An important aspect of trauma to watch out for as patients experience it over time. So, what about PTSD in particular? Well, it's been talked about greatly, studied greatly. We have a perspective which many share, but not all. First off, PTSD is not uncommon at all, and perhaps maybe the most common psychiatric disorder over a lifetime. Over a lifetime, there's a very high probability that you will be exposed to some type of life-threatening event, whether that's a natural disaster, a war, or a motor vehicle accident. So perhaps nearly everyone has an acute form of PTSD at some point in time. You know, if you were in a car accident, and then over the following month, you in fact jumped when the brakes went on behind you, you had several nightmares, and you decided not to go into work because you wanted to take a few days off, and maybe you also decided not to watch the car racing on television, you would qualify for a diagnosis of PTSD. At the same time, you probably recovered. That the vast majority of PTSD is that from which we experience and recovery happens. It's also clear that people can develop PTSD without other psychiatric history. Now, that's not to say that people with a previous psychiatric history aren't at greater risk. That's certainly true, but that's not the news. The news is that people without psychiatric history, as best we can determine through a good group of studies, show that people without previous psychiatric history can in fact develop PTSD. This is one of the areas where I think we in the psychoanalytic and psychodynamic community can do a misservice and get misled by our thinking. If we're always looking for the vulnerability, this person had to have something in their background. They must have had something or else they wouldn't have developed this. Well, what about the possibility that some people don't have something in their background? And it's the elements and experience of the present which breaks them, that alters the experience of the ego and the superego and the id. So we did one study, and I don't know that it's in here, but looking at prisoners of war from Vietnam. It's written up and published in the American Journal of Psychiatry, which is written from a psychodynamic perspective on asking about what happens when people experience trauma. And through a series of case studies, we talked about what pressures are on the superego during a trauma experience, and what pressures are on, in particular, the ego ideal in certain trauma experiences of trying to live up to what one sees as one's beliefs and goals, and that those are an inherent part of the experience that can perhaps mold the personality in adulthood by how we face the pressures of the moment rather than necessarily our vulnerabilities from the past. I think we do a disservice to our patients and our science by always having to find that this person really was vulnerable. Well, I think we're changing the goal line when we do that at times, rather than helping understand and better inform how to treat our patients. So, what is PTSD? There's lots of ways to think about it. One might be that it is the inability to digest early stress symptoms. So that would go along with the picture that when you're exposed to a traumatic event, nearly everybody develops some symptoms. But many people digest it. It goes away. But for some people, it doesn't. In that case, we'd be saying that PTSD is an impairment of the digestive system of the brain. What is the digestive system of the brain, or for that matter, the digestive system of the personality? And how does it function to reestablish recovery? So, if we take another perspective, somewhat related, perhaps PTSD, the exposure to a traumatic event, is creating an altered set point. So what do I mean by set point? So if I take a bar of steel and I try to bend it at normal room temperature, there is an equation that my engineering friends could tell me that would predict how that would bend. But if I then told them that, okay, so now I'm going to lower the temperature of this steel to minus 273 degrees centigrade, which is 0 degrees Kelvin, then they would tell me that actually, hold on there, you can't use that equation anymore because the equation is different now. We have altered the set point. So it's not that the brain or the personality is doing something wrong then after exposure to trauma. It's doing something absolutely right, but it's set for 0 degrees Kelvin instead of normal temperature. The set point has changed, and the set point hasn't been reset. Another picture, and each of these are perspectives that lead to a whole range of research, and how you formulate this question leads to different ways of asking your research, and also different ways of treating your patient as to what you think the disorder is. What is it you're really treating? Are you treating the set point? Are you treating the digestive system? Well, another might be that we know that PTSD, for example, you can have intrusion, avoidance, hyperarousal, negative affect. You can have 2 of those or 3 of those, or on one day you have 2, another day you have 3. But we only call it PTSD when you have all of them, when they are all present and they all stay. So perhaps PTSD is then the glue, the brain glue that makes when the symptoms show up, they stick. So then our treatment would be directed towards changing the glue. The perspective that we like a lot at my center and the university is one shared here in a cartoon by McNulty about Zambezi. Walking beside Zambezi, Congo felt very happy. I have a super memory, he said to himself, and I will always remember what to forget. Important statement because it defines then that PTSD is not in fact a remembering disorder, frequently thought of as because of the focus on intrusive symptoms, but it actually is a forgetting disorder. It's a problem in our ability to forget. And in psychoanalysis, another area where I think we do a disservice by not thinking more broadly is that forgetting can be powerful and adaptive and is a normal mechanism for recovery. That forgetting gets a bad rap in much of our psychoanalytic thinking, and it gets a bad rap in neurobiology because of our focus on Alzheimer's. But in fact, forgetting may be the most important element of brain function. If we didn't forget, our heads would explode. We'd be taking too much in. We have to have a way to be able to forget, to be able to refresh and take in new knowledge, new information, and new observations. So in this case, the problem of PTSD is what is impaired in our forgetting process. And if you ask that with a patient, you'll be thinking very differently about how you will be listening to the stories they'll tell you. Not just about what they are remembering, but why haven't they forgotten this one? Why is that forgetting process not allowing this to go away? What is our forgetting process? So, jump to another perspective. Another way to think about PTSD. And again, each of these is a perspective, a different way of thinking about this disorder or trauma exposure in general, but PTSD in particular. So this particular study, which was done quite a while back, was looking at a group of volunteers who worked in a mortuary following a disaster. So they're exposed to death and dead bodies. Now, we know that exposure to death and the dead is one of the elements that cuts across many traumatic events, disasters, and war. So understanding what is the experience of exposure to death and the dead can be an important aspect of understanding the process of disease development and recovery. One of the things that we did with this group, and these were airmen up at Dover Air Force Base, working in the mortuary, and they were all volunteers. These were not trained individuals. And we asked them about to what extent the bodies reminded them of a friend, reminded them of a spouse, reminded them of a relative, reminded them of a friend. And we called that identification, that they identified with, could have reminded them of themselves. The more the identification, the more the person reported, this is similar to my name the person, self, father, brother, sister, mother, the more likely they were to, in fact, develop PTSD. So this observation, not only made by us, but also by others, has been used in working with first responders to aid them in not identifying with the victims. So we think a lot about identification in the world of psychodynamics and psychoanalysis, and usually think about it as a healthy process. We identify with mother, we identify with father, we identify with sister, brother, mentors. It's an aspect of our growth and development. It's also true that we disidentify, a term more often used in child psychiatry perhaps than adult, but the disidentification is also an important developmental process towards our growth and development. Well, in this case, a normal mechanism of our brain and our personality, in fact, increases our rate of disease and disorder. So that's why we termed it, maybe PTSD, as an autoimmune disorder, similar to having our immune system misfiring and attacking our own organs, which occurs with some disorders that we know in medicine, such as systemic lupus erythematosus or arthritis or thyroiditis. Perhaps also our identification system can actually, in some settings, increase our disorder and not just protect us as an aspect of normal growth and development. So in this example, the intervention would be how to decrease identification. It would also be asking about who is more likely to identify. Can we decrease their exposure if they are a high identifier? Is identification a trait, meaning it's like a gene you've got, and once you've got it, you've always got it? Or is it a state, meaning it's turned on and turned off by certain experiences? And certainly it's got to be some combination of that. So the ability to remember and the ability to forget are important. And let me just mention, skip to 6 here, that another way to talk about trauma exposure is think of toxic exposures, and that often is a helpful way of talking about to community leaders, whether that is leaders of soldiers or mayors of a town who have a disaster or a contamination that has occurred, such as recently here in the United States in Flint, Michigan, where a substantial community found out that their water had essentially been contaminated with lead for many years. So this slide is one that relates to the picture of identification. And if you see in the near top right, identification means, in this case, thinking by similarity. Really, you see the familiar, you see that dead body as being like someone you know, when in fact they aren't at all. They're a different person, they're in a different setting, they may be a different age, but you are seeing things as if they're familiar even when they aren't. And this drawing was our putting together a way in which we would explore and study this aspect of personality or brain function and how it may increase risk for altered behaviors and feelings after these experiences. I would add another piece to this, which is why I like this topic in particular. Because if you think of identification as thinking by similarity, there is another very important concept in the world of psychodynamics and psychoanalysis, which is also thinking by similarity, and that's transference. The transference is actually thinking by similarity. We are responding to someone as if they were someone familiar to us and someone from the past. We are thinking by similarity rather than noticing the differences that are present. So is thinking by similarity a broad brain function which shows up in certain characteristic ways that we observe in psychotherapy and psychoanalysis, ways which may be important to development, identification, and also ways that may actually increase the probability of disease and disorder, when it occurs or gets turned on in settings where it's not helpful, that it actually increases arousal and distress rather than helping to decrease arousal and distress. So this concept of thinking by similarity is a broad perspective on brain function that may encompass other elements of what we think of as personality function. One other part of this slide I would draw your attention to, which I think is another one where psychodynamic and psychoanalytic psychotherapy has much to offer, and it's been previously reported on. There's a wonderful book, and I'm forgetting the author right now, but the experience of safety. We know very little about safety as an experience. We focus on anxiety, we focus on distress, but safety is not the same thing as just absence of anxiety or absence of distress. That safety is a different experience. And using our psychoanalytic and psychodynamic tools to observe patients, we would aid the broad science by trying to understand the safety experience and how it changes over time. Who is more likely to experience safety? What prevents the experience of safety? What is the developmental line of feeling safe? How does it get disrupted? Another affect experience that the microscope of psychoanalytic observation and psychodynamic observation could contribute greatly to develop hypotheses for empirical sciences to further test. So let's not forget genes. You'll see here, thinking back now to PTSD, and certainly genes have a contribution to this, that when we think of how many genes there are in the human genome, we've gone from 100,000 down to about 23,000. And that's about the number we seem to be settling on. But lest we get too excited, I always like to remind us that the grape actually has more genes than we do, and the chicken almost as many genes as we do. So genes in and of themselves are not the answer. Otherwise, the grape would be running the world. So there's much to learn in this area. We do know that a number of genes have been related to PTSD, and some of our own work has contributed to this, most recently in looking at soldiers and war. Oh. Hi, I see Jeffrey Yarvis. Hi, Jeff. You can't see me only because this doesn't work. You should be getting ready to speak soon, I think. So you'll see here a list of genes, and I wouldn't focus on any particular gene these days. FKBP5 may be the one of most interest and the strongest data, P11, one we're working on. But it is important to keep track of the story because it brings a whole nother perspective on how we might look at the world. And another aspect of gene function, which is much closer to psychodynamic work, is that of thinking about methylation. That in fact, what turns our genes on and off is probably much more important to our treatments, psychotherapeutic and psychoanalytic treatments, because that's what we're trying to do. If we're trying to create a sustained alteration in behavior, then we are, in fact, eventually trying to change the methylation or histone changes that lead to genes being more or less turned on. You can't change which genes you have, but which genes are working in any given tissue or at any given time are in fact controlled by the methylation process and several other processes. And psychotherapy in and of itself, to the extent it changes behavior, it is in fact operating in epigenetic mechanisms, as you see here. So I'm not quite sure,
Jeff, when I'm supposed to stop here, but I know it's soon because you're supposed to talk. So let me quickly run through this, and if anybody wants to say, Bob, stop, just scream. So this is the quiz, and it has to do with treatment. So you get to answer yes or no on each one of these. Debriefing, yes or no. EMDR, yes or no. CBT, benzodiazepines, SSRIs, we can prevent PTSD. We should intervene early to prevent PTSD. Psychodynamic treatment is irrelevant. All right? Now the answers. And of course, we won't explore all of them, but it's a good provocative way to talk and also to end on a clinical note. Debriefing, no. Debriefing is no longer the recommended intervention after acute traumatic events. What is? Psychological first aid. Now, I distinguish here what we talk of as debriefing versus what one might think of as an operational debriefing with a group that works together like firefighters or soldiers. Different question. Debriefing itself was developed, take everybody who was exposed to a traumatic event, bring them together and let's talk about it. What we found is that in doing so, you actually increase symptoms in numerous people who didn't have the same exposure as everyone else. Psychological first aid, which we didn't talk about here, is an important concept that has organized early intervention now for about the past perhaps 6 or 8 years. An important article actually published in the journal that I edit. Steve Hopful is the first author on that article, which outlines the principles of psychological first aid. And there are programs developed principally with the VA and also the Red Cross that highlight that. EMDR, no, yes, and no. Would I learn EMDR? No. Is EMDR effective? Yes. But what is effective about it? What appears to be effective is its CBT elements, not in fact the eye movements. So if someone asks me, well, I want to go take a course, should I take an EMDR course? I say no, take a CBT course, because the CBT course will be more applicable and more broadly. And there are at least 2 types of CBT that have strong evidence for their effectiveness in the treatment of PTSD, and is most likely the treatment of choice for early PTSD, and a trial of CBT is very important. Benzodiazepines are not recommended, although the studies are few. What studies there are indicate that they increase symptoms. SSRIs, which are our utility horse in the treatment of psychiatric disorders. These are our so-called antidepressants, but they aren't antidepressants. They're antidepressant, anti-anxiety, anti-panic. Yes, they have a substantial impact on PTSD. Some literature saying perhaps somewhat less for war-related PTSD than for other types of PTSD, and that may reflect the issues of chronic ongoing exposure versus single event exposure in those 2 different types of PTSD. Should we intervene early? Well, Richard Bryant has shown, and very important to tell people about, that yes, we can prevent PTSD. We can prevent it with early CBT. In Richard's study, he had CBT administered at about 3 weeks after the traumatic event. Now, here's the catch. The question is, how early? Because the earlier you do it after the event, the more likely you're catching people that in fact will recover anyway, and that you may actually have negative impacts with. So that was why he chose 3 weeks. Now, the other challenge is, for large-scale disasters, you would have to treat a lot of people who, in fact, would be recovering anyway. So what's the role of CBT? And that's why the development of internet-distributed CBT can be an important element in treatment in disaster settings and in widely dispersed populations, which includes soldiers that may be widely distributed throughout a nation and not able to access other elements of treatment. And then lastly, psychodynamic treatment. Of course it's important. And it's important, however, when one gets to questions of complex, persistent PTSD. It is not the first choice for treatment of PTSD. But when PTSD has gone on for a long time, and it's deeply embedded in character elements, and may be associated with other comorbidities, one needs a more complex treatment that can address a wide range of the way in which life is experienced and how people behave after trauma events, and not only the cluster of the PTSD symptoms themselves. There are a number of other issues one could talk about and pick up on, but I'll leave those for now. Jeff, when are you scheduled to talk? I'm waiting for one of our moderators to pop on here. I thought it might be 8:30.
I'm popping on, and what I'd suggest is that we see if the audience has any questions for Dr. Ursano first. If you have a question, you can use the chat feature at the bottom of the, if you move your cursor to the bottom of the screen, the chat feature will pop up. And while people are typing their questions, I just wanted to thank Dr. Ursano for this amazing presentation, but also my ears kept perking up at your idea of having clinicians track what goes on in a psychotherapy or a psychoanalysis when a stress disorder or a PTSD disorder is present. I think that would be a wonderful study.
So I think it's remarkably valuable. There is no place better than a psychotherapy to be able to track longitudinally the moment-to-moment changes in a patient. You know, we have research strategies that try to do that, but we don't get the fine detail that one can get in a psychotherapy. I remember one of my most enjoyable training psychotherapies in which I was seeing patients very frequently. I took the brief psychiatric rating scale, and every time I saw the patient, I rated the patient. And I went back and looked at what was it I said the session before when I actually saw a change in the scale. And it was a very informative approach. But there are elements one can observe in a psychotherapy that you can't anywhere else. We just don't have measures to be able to do that. We don't have the type of microscopic detail that we can elicit while looking at tissue when we try and look at affects and affects during a day or affects over a week, and to wonder how those changes related to whether or not the spouse or partner was present, or whether or not the person was angry or not the day before, or for that matter, whether or not they drank the day before or 3 days before or a week before. Or for that matter, another important topic these days is hostility. Does hostility precede symptoms or come after the symptoms? We know that hostility is an important part of PTSD now. It's included irritability as one of the symptom lines, and yet we know very little about the course of irritability in the treatment of a trauma disorder. And does irritability come before intrusion? Is the person angry and that night has a nightmare? That's kind of a classic psychodynamic. But what about the other way around? What about they weren't angry, they had a nightmare and then they're angry? All of those are important observations and could create a very interesting paradigm.
Yeah, because my little brain was churning the whole time, reviewing a number of cases as you were talking. It always fascinates me what happened between the patient and the therapist that may have enabled something to happen, and then to track that over time, which always fascinates me.
Yes, yes. Particularly, I mean, the altered attachment between patient and therapist, the disruption of transference as a measure of moving from thinking of similarity to not thinking by similarity, and what happened. Many ways to frame it, depending on the flavor that you want to bring to it, but all important observations.
And I keep mulling over your reminder that forgetting is important. that it because thinking about several of the patients I've worked with, it's interesting. This process of forgetting is many times a very good thing. It's not like I think people confuse forgetting with repression or suppression, and I think they're very different things.
Yeah, I would agree. Now, I think in the broadest view of psychotherapy, we're trying to get people to remember so they can forget. And we've studied the remembering part of that. We haven't studied the forgetting part of it. We work hard to help people remember, but then we don't look at what happens after they remember. How come this time they're able to forget it, and the previous time they remembered they weren't?
Or the terms of what we might call it reactivity. What are the elements that trigger a remembrance? And was it a physical experience? Was it an auditory experience? I mean, just the varieties of things that can trigger a reactive or a remembering. I find fascinating also, but it's...
Yeah. There's a wonderful article, I think it was by Marty Horowitz, I can't swear to that talked about a psychoanalysis, and he particularly observed how the patient moved from experiencing in one modality versus another, and what triggered that. So if the patient was reporting things that were visual, and then later on in the session or the next session, primarily reporting auditory events. What in fact led to that switch of focus in terms of the way in which the patient was experiencing.
Jeff, can you unmute and read us the question that you were able to see? For some reason, my question and answer screen isn't working.
It's from William Kenner in Nashville. It says the meaning of trauma gets identifications as well as the meanings of effects of the trauma. Sorry about that.
Good, what are you doing? Can you type that in the chat box for me? I couldn't quite hear you.
Jeff, you're going to keep getting feedback with both of the computers on.
Jeff, we have two views of Jeff. We're going to work on three. Because Dr. Sato, I'm working with long-term HIV survivors. One of the most, a very interesting encounter I had was where, after doing a lot of work on several near-death illnesses and things going along quite smoothly, the act of the dog causing my patient to trip down the stairs brought the whole thing back. And he was able to say that something about that split second in the air and that feeling of being in the air, not knowing where he was going, reminded him so much of not knowing. It reminded him of being so critically ill.
Right. There's a way in which the traumatic event and its recall can be trying to describe our present experience as to what we're worried about, as well as what we had in the past. Similar piece we had, which I did with a colleague of Harry Holloway, looking at individuals who were diagnosed with cancer in the hospital, and many of them had during that time the recall of their combat experiences and intrusive dreams and nightmares. And an important aspect of talking with them was not to talk about the combat experience per se, but to recognize how it was reflecting their present worries about whether they were going to live or die. And it wasn't remembering the past as it was trying to symbolize the present in that setting. So the question of where we focus as to what's being recalled or presently trying to be experienced can carry an important accent as to how we focus with the patient.
That's a wonderful. Can we like write that on a tablet in gold and pass it around to all of our graduate students?
Yeah, we wrote.
Well, it's an important reminder about the complexity of what we're doing.
Yes, yes, we wrote that up in an article, and actually, long before I was the editor of Psychiatry, Don Burnham, who was a brilliant and wonderful man, now long past, he wrote the Need-Fear Dilemma, psychoanalyst, and he was the editor, and we submitted the article actually to him, and he made the most critical recommendation on his review, which was to refer us to papers in which he had used the phrase the symbolic vehicle, and how we at times are creating symbolic vehicles to express our experience.
Okay.
And it's not so much the past or the present as it is to try to grab the meaning of what we're presently experiencing. And we use the bricks from the past because that's what we have.
It's wonderful. We've got a question here from Bill Kenner in Nashville, that he states the meaning of the trauma gets at identifications as well as the meanings of the effects of trauma. That it's more of a statement than a question, I think, but.
Yeah, and there is certainly a connection between our meaning-making functions and our identifications. And meaning-making would be close to this idea of symbolic vehicle, that a part of our brain is always trying to interpret what's in front of us. And thank goodness, you know, if we did not recognize lions, tigers, and bears, we'd be long dead. So, and what we use for constructing that meaning is our past experience. So our past experience are the bricks under which we classify our present experience, which is what we call meaning. We create meaning in it. And it is those experiences with the past that allow us to try to conceptualize what's in the present. And we can only use what bricks we have, depending on what our experience has been. We can't use ones that other people have had. And sometimes our bricks are not as subtle as they could be if we had other experiences. Maybe part of psychotherapy is to enable someone to be able to develop new bricks, new ways of phrasing that they haven't had before, so that they can better provide meaning to their present experience as well as meaning to their past experience.
Very nice.
I was always impressed with a patient I had at one time who had significant obsessive compulsive problems, and whenever he got into an argument, it was like a nuclear blast went off. You know, he didn't have the idea of instead of using a nuclear device when he was angry, using a pea shooter. You know, he didn't have a range of how to classify anger and aggression. It was just anger and aggression on, anger and aggression off. So I felt the therapy was moving well when he began to have graded responses and to experience graded attacks at the same time, rather than everything was a nuclear blow and he had to bring out a nuclear weapon.
Very nice. Dr. Sano, thank you so much for helping us out. And
thank you.
Again, the recording of this will be housed on our website. We're trying to build a psychoanalytic, psychodynamic library on the American Psychoanalytic Association website. So clinicians, we're always encouraging our clinicians to volunteer for the different organizations out there, and also to remember that psychoanalysis has been working on this since 1917, 1918, really 1915. And it's interesting to hear a lot of echoes that in the research that kind of still ring true, and some of them don't. But so thank you so much again, and
thank you. It's been a pleasure.
Big thanks.
Bye.
Bye now.
Bye.
We'll just take a minute here and get our screen switched around, and I believe Jeff has a PowerPoint he wants to load up, and while he's doing that, I'm going to introduce him. Colonel Jeffrey Yarbus, PhD, is an old buddy of mine. We had a grand adventure setting up a doctoral level specialization in military veterans clinical social work. He's a published social work and military scholar in the field of psychological trauma for nearly 30 years. He doesn't look like it, does it? He looks kind of young for that. He's practiced internationally with disaster, domestic violence, child abuse, sexual abuse, accident, and war-induced trauma across many different cultures and populations. He has conducted international research and partnerships in Canada, Iraq, Germany, Ukraine, and Romania on issues related to PTSD, and presented his work to over 100 national and international conferences. He has received numerous honors for his humanitarian efforts to include, in 2015, the top 100 executives under 50. In 2008, Uniformed Services Social Worker of the Year, which he never told me about. In 2008, the Army and the 1997 Mental Health Professional of the Year, and the Randolph High School, New Jersey Hall of Fame, save the best for last. He's got numerous decorations and include the Bronze Star, Combat Action Badge, and induction to the Order of Military Medical Merit. Received his U.S. Army Alpha Proficiency Designator as a full professor and military scholar in social work. And Colonel Yarbus is adjunct faculty for the University of Southern California Military Social Work Program, Virtual Academic Center, and an adjunct instructor for Texas State University. And he's currently deputy commander of one of the Army's premier medical centers. Jeffrey, all yours.
Great. And just one technical thing. Do I just share my screen, Dennis, to get the PowerPoint? I can't remember what we talked about the other day.
If you roll your cursor down to the bottom of your screen, you'll see a green share screen sign.
Yep.
Click that, and it'll give you the options and go to your PowerPoint. Is your PowerPoint open and running?
Yes.
Okay, you should see it in the box.
Okay. I didn't see it. That's why I was kind of like, hey, all right, hold on. I think I'm gonna have to okay, there we go. There we go. And I can make it into.
If you just hit start your slideshow, it'll take over your screen and away you go.
All right, awesome. Well,
and I'm going to bug out and be quiet.
All right, fantastic.
I'll be listening.
All right. Well, it's great to do this. This is something that's really important to me. And before we get going, because I'm sprinting from work, I just want to say that what I'm going to talk about is very sensitive, but unclassified, and represents my opinions and not the opinions of the Carl R. Darnell Army Medical Center, or the U.S. Army, or the Army Medical Department. And that said, one of the things I'd like to talk to you about, apart from the research, treatment, and pathology that we'll talk about a little bit, is the intimacy of trauma. What really goes on between people and some of the things they struggle with, and the things that you're probably dealing with in your practices, but often aren't captured in the research, aren't spoken about between therapists and patients sometimes, and talk about what that's like to come home. And you'll notice that the title says returning versus wounded or traumatized, because most of our warriors return home as opposed to coming home wounded. And so what is it about them? Do they have problems? Do they experience pathology? What happens if they don't meet a diagnostic cutoff? Are they sick or are they okay? Do the symptoms abate or don't they abate? So these are some of the kinds of things I hope to shed some light on for you. It's probably good to talk about what a veteran is. The conventional definition of this is somebody who has served but I like to say we all serve. So this would include the veterans and their family and the current service member. And for me, this discussion is really a great opportunity to share with you something I'm very passionate about. It's not just a vocation. It's not something I'm just interested in doing research in, but it's really a personal mandate. And I can say easily that even though I've never met any of you, that I really love you for what you do, because if we get this right, if we do the work well, if you learn psychodynamic psychotherapies and evidence-based therapies out there, if you treat people with compassion and treat them well, you're going to be taking care of people like me and my family. And so so getting this right is both personally important and professionally important. So I hope to kind of give you a little bit of a cultural boot camp along the way. And this will be a combination of research findings and tales from psychotherapy, as it were. And so in order to do that with this population, it's interesting. A lot of times mental health associations sort of distance themselves from the military, which is somewhat amazing to me, partly because some of us got our start with study of the military. Smith College of Social Work, for example, began its work after they noticed that veterans coming home from World War I were homeless, struggling to get care, acting out in ways that they hadn't seen before. But today's society views sometimes along political lines, and so we find ourselves not being understood. We find ourselves being undertreated, overrepresented in populations such as homelessness and incarcerated populations. And essentially we're culturally misunderstood. So not to patronize anybody, but it's probably worth noting that, you know, the military, like any misunderstood population, needs to be treated with a degree of competence. And I can't see you at the moment, but a lot of times when I ask people how many of you know a veteran or worked with a veteran, actually, I'm sorry. If I ask people how many of you have worked with a veteran, very few hands go up. But if I say how many of you know a veteran, many hands go up. So they're not completely foreign to you. And it's really important to recognize when people ask, well, how do you guys, as if we're one big green or big blue blob, how do we feel about things? I'll tell them that we're a representative sample of the United States or the country that we're in the military from. So we have all the problems that our societies have. We have the cultural diversity that our societies have. And we tend to sometimes have our unique needs because we have this extra layer of rules and cultural norms imposed on us. And so we'll talk a little bit about that when it comes to help seeking, because there's an interplay between the warrior ethos and help seeking. But in general, we're not too foreign from you. We have men and women, we have gay and straight, we have people of different cultures and religions and ethnicities. And so they're much more familiar than you think. And they tend to believe the same things the larger society believes and struggle with the things that the larger society struggles with. So cultural competence involves essentially 4 stages. And you know, the first stage is generally where we find our interns. They don't know what they don't know, so they get their butts in a jam. And then hopefully over the course of educating them, they develop a sense of they know some things, but they know that there's this whole vast literature out there that they're not completely familiar with. And hopefully most of us reach, by the time we're licensed, a state of conscious competence where we feel very comfortable in wielding the weapons of our trade, but we know we have the opportunity to learn. And sort of the self-actualization of competence would be the last stage, unconscious competence, which would be essentially where we're agile, we don't have to think a lot, we have good instincts, we can anticipate where our questions are going to take the patient before we get there, we expect aberrant reactions to things, and we constantly inform our practice. And there are some situations where we just can't be unconsciously competent. Say, for example, I was raised by African American parents. I might identify myself as being culturally Black, but my whiteness gives me certain advantages, and people in the larger Black community outside of my family would not necessarily accept the fact that that's true, because I have experiences that will be different than people of color, for example. And sometimes people will talk to us in the military in ways that are inappropriate without realizing it. And you could imagine, for example, if somebody used a particular slang that they thought a culture used when they sat down with a person who was different from them for the first time, how that patient might react. Yet sometimes people will do that with us thinking that that's how we all speak to each other, whether it's swearing at each other or making sweeping generalizations based on a Rambo movie they might have watched at some time. So enough of that, and I appreciate you indulging me on that for a moment. Sometimes people don't understand why we would join, but if you look at the values of the different services here in the US, they're not too different than the values of our different professional underpinnings. They're not different from the things we learn in school and the things that our churches and synagogues talk to us about. So this shouldn't be too far, and many of these ideas resonate with people who were raised with certain traditions and can see that again through the service language. I just want to go off on a tangent for a moment and talk about women in the service of war. This is Monica Lynn Brown. She was the first Silver Star recipient. But here in the US, women are now able to serve in full capacities alongside their male counterparts. And while women have been on the battlefield since battles occurred, either traveling with their warrior husbands, or in the case of the United States, as Molly pitchers, we don't know a lot about this generation of women and how their experiences ultimately translate into trauma. So it'll be really interesting to see how they communicate their experiences through research as time goes forward. It's probably also worth noting about women that our society is probably less prepared to see them come back wounded. So while they're openly integrated, fully integrated, people